Our afternoon plenary speaker, the first speaker is Dr. Sanjeev Arora. He's the director of Project ECHO, which is the extension for community healthcare outcomes. He's also a tenured professor in the Department of Internal. He has been involved in the management of viral hepatitis for over 15 years and led the development of implementation of hepatitis C as a platform for service delivery, education, and evaluation. He is definitely an authority, so without further ado, let's welcome Dr. Sanjeev Arora.
But thank you for this opportunity. At ECHO stands for Extension for Community Healthcare Outcomes, and our mission is to democratize medical knowledge and get best practice care for underserved people all over the world. Our goal is to touch the lives of 1 billion people by 2025. The key principle in Project ECHO is to move knowledge instead of moving patients. Hepatitis C, which affects 170 million people worldwide. This is a curable disease. It's expected 40 million people will die from this because only 2% of the world's population has actually received treatment for this condition. In 2004, less than 5% of them had been treated. There were also 2,300 prisoners. None had been treated. The good news about hepatitis C is it's curable. But in 2004, the problem was that it required chemotherapy-like regimen with interferon, ribavirin, chemotherapy, so no primary care doctor was treating hepatitis C because of severe side effects of anemia, neutropenia, depression, and we are a rural, underserved state. So we developed Project ECHO to develop the capacity to safely and effectively treat hepatitis C everywhere. And then we knew that if we could do this for hepatitis C, we would have a model for complex diseases in rural locations and in developing countries. We developed partnerships between the university, the prisons, the health department, to leverage the expertise of super specialist teams like a liver specialist like me, a pharmacist and a psychiatrist. We share best practices. So we created the best practice guideline for treating hepatitis C and 5 in prisons. The third key challenge was how do we make a primary care doctor who's running these centers, how do we make them as expert as super specialty teams at the university? We said we would train them the same way of how I became an expert when I was training as a gastroenterologist in the United States. I would see a patient, present it to my professors, they would tell me how to manage the patients, and then I would go and apply that. This process of guided practice creates expertise quickly, and then we would have a web-based database to monitor outcomes. This is giving me a buzzer saying that it looks like the battery is off. No. So what we do is we have a web-based database to monitor outcomes, software, and then we conduct these clinics called knowledge networks. This is what a knowledge network looks like. On the big box is our University of New Mexico liver specialist, psychiatrist, pharmacist, then Chris Rugi. Over the course of 2 hours, we co-manage about 12 patients of hepatitis C. And we give them a brief 15-minute lecture on some aspect of hepatitis C on which we want to train them. Oops. Again, I think we call these knowledge networks. No patient ever comes onto this network. And the way they become experts is called a learning loop, that they learn from our advice, they learn from each other, they learn by doing. Most important thing is to learn by doing, because if you wanted to teach your daughter to drive a car, you couldn't give her lectures or give her access to a website. In order for her to become an expert, you would need to sit next to her and hold her hand. And so essentially, the principle of ECHO is what we call guided practice. We give these by bringing a mix of work and learning into their life and giving them access to multiple specialists at the same time. The technology, the only technology that is required in the rural area to do Project ECHO. We've done 550 such clinics. More than 5,500 patients have entered this disease management program. We provided 63,000 hours of CME credit to rural clinicians in New Mexico alone. Worldwide, we have provided millions of hours of CME credit. The first thing we wanted to study was no doctor is going to treat hepatitis C with chemotherapy unless they feel confident. We asked them, what is your ability to identify suitable candidates for treatment? The scale is 1, I have no skill, 7, I'm an expert who can teach others. Goes from 2.8 to 5.6 in 12 months. Question 3, ability to treat hepatitis C and manage side effects, 2 to 5.1. Can you now serve as a local consultant within your area? 2.4 to 5.6. Overall competence, 2.8 to 5.5. Is enhanced knowledge and management a benefit to you? So is very beneficial to them. Has diminished my professional isolation, 4.3 out of 5. Enhanced my professional satisfaction, 4.8. Is a benefit to my clinic, 4.9. Expands access. We published in the New England Journal of Medicine in June of 2011. Objectives were to train primary care clinicians in rural areas to show that such care is as safe and effective as a university, and we can improve care for minorities. The experiment was 21 community clinics and prisons, and control was University of New Mexico Liver Clinic. The principal endpoint was a sustained viral response, a cure. If you cure hepatitis C virus, you can reduce the likelihood of dying from it by 93%. These are the final results. Cure rate in the rural areas was 50% for genotype 1, 46 at the university, for genotype 2 and 3, 70, 71. Our conclusions were that rural primary care clinicians deliver hepatitis C care that is as safe and effective as a university clinic, and that we can improve access to care for minorities. After that, we discussed and with the serious outcomes of untreated disease, and if you have effective treatments, you could use this model. We use the Pareto's principle, which is the 80-20 rule, because only a small number of diseases account for most of the morbidity, mortality, like chronic, by providing the same level of care at a community health center as we do at the university, and we do this by using technology, best practices, case-based learning, and outcomes tracking. This is the second most important slide. This is the goal of Project ECHO. We call it force multiplier. That's what ECHO model is. It's a force multiplier. It's a term we have coined in healthcare to define a logarithmic improvement in capacity. Why do we need a logarithmic improvement in capacity? Overall, there are 7 billion people in the world. We think more than 6 billion don't get access to best practice care. So if you double the number of specialists, nothing is going to happen, essentially. You need 10 to 100 times the specialty expertise that is needed if you want to make a huge impact in the world. How do we do force multiplication with ECHO? First, we use existing all the way to Africa. So we use existing providers, and the second thing is, if a nurse practitioner, physician assistant, and a primary care doctor can provide the same level of care as a super specialist, then problems, hepatitis C, diabetes, endocrinology consultation, geriatrics, dementia, palliative care, complex care, integrated addiction, psychiatry, chronic pain, rheumatology, HIV, women's health, genomics. This is New Mexico. We have about 2.4 million people. There are 400 points of contact in ECHO connected to the University of New Mexico. The vision is in one area, at the bottom right is Carlsbad. We want, in that town where there are no specialists, one expert in HIV, one in rheumatology, one in endocrinology, one in substance use, so that they can create a self-sustaining network. You know, there's something wrong with this clicker. Okay. The reason we need these knowledge networks is because medical knowledge is increasing exponentially. You can get best practice care unless you have some different model. And the last part of the force multiplier is that chronic disease management is a team sport. That we also train community health workers, medical assistants. So the reason why community health workers' interventions are effective is they live in the community, understand the culture, appreciate economic limitations, know the family, but mostly they spend more time with the patient. We have 4 such training programs. One is our CREW, diabetes program. CARS is community addiction recovery specialists. Prison program. So a typical program looks like these. Community health workers come for a 3-day training, after which we give them their webcams. They go home and they join us every week on a weekly call where we join them on video, when we train them on diet, exercise, smoking cessation, reminders, finger sticks, foot exams. This is our prison program. We have trained 400 community health workers specialists in prison, who in turn have trained thousands of prisoners on how not to get HIV, hepatitis C, sexually transmitted diseases. This is their graduation ceremony. Over to any health system anywhere in the world, including the United States, is improved quality and safety, rapid learning, reducing variation, access to rural underserved patients, workforce training, democratizing knowledge, improving. This is our hepatitis C program in New Mexico. This is the 400 points of contact all over New Mexico. These are all the universities. There are 52 universities all over the world that have replicated ECHO. Starting from the left, University of Washington, middle, University of Chicago, Harvard, University of South Florida, Nevada, UCSF, University of Michigan, and every major university is replicating Project ECHO right now. And this is the VA ECHO program, 600 clinics connected to 11 university hubs. These are the international sites in Argentina, Vietnam, India, Canada, Ireland, etc. This is our team. The reason why ECHO works is shown on this slide. This is the last slide area. The role of task shifting, making everyone work at the highest level of competence. The importance of interprofessional consultation, where no one expert in a university can actually provide best practice care. We develop mentor-mentee relationships between experts at the university and build a community of practice, which is also a social network to improve joy of work. But ultimately, to reach 1 billion people, I'm inviting all of you to join ECHO. You should reach out to me after this talk if you're interested, or you can go to our website. But we are trying to create a movement rather than build an organization. In order to touch 1 billion people, no organization can be large enough. But if many of you start ECHO projects, we'll be successful. Thank you for your attention.